today our group 10 is going to present on the research paper CAPTURE-GAN, Conditional Attribute Preservation through Unveiling Realistic GAN for Artifact Removal in Dual Energy CT Imaging. This work explores a generative adversarial network on GAN-based framework developed specifically for artifact removal in dual energy CT imaging, with a critical focus on preserving key diagnostic features such as bone marrow edema. This paper is authored by researchers from Busan National University, Korea, including Chunsu Park, Seunho Kim, Dongyeon Lee, Seo Lee, Ashok Kambalaru, and Minwoo Kim, who is also the corresponding author. The motivation behind this work comes from a practical and clinical challenge: enhancing DECT scans using AI without compromising diagnostic accuracy, a problem that many existing models fail to solve well. Capture GAN is proposed as a targeted domain aware solution to that challenge. Now, let us begin by looking at the context of this research paper. So, first of all, let us ex- tell what DECT basically is. Dual energy computed tomography, or DECT, is increasingly used to detect conditions like bone marrow edema, which is an early indicator of bone damage or fractures. It offers benefits over traditional imaging methods by allowing material decomposition, essentially separating different tissue types like water and bone. However, it has some major issues. First of all, it has lower contrast than MRI, making it harder to pick out subtle fluid accumulations or early stage pathologies. And DECT images often contain artifacts which are unwanted visual distortions introduced during scanning and reconstruction. These artifacts are a problem because they hide actual abnormalities and mimic pathological features like edema, which creates confusion and diagnosing becomes difficult. Several AI based methods have tried to help by enhancing these images. However, most of them operate in a supervised setting, means they require paired data. For example, one image with artifacts and the exact same image without them. In real world, that kind of ground truth data is nearly impossible to obtain, especially in medical imaging. Even unsupervised models like CycleGAN or AdGAN aren't well suited here. These cannot often tell the difference between an artifact and a disease feature because both can look very similar. So this leads us to our proposed framework CAPTURE-GAN, short for Conditional Attribute Preservation through Unveiling Realistic GAN. The core objective of CAPTURE-GAN is to remove artifacts from DECT images without compromising the important diagnostic features, particularly bone marrow edema patterns and fine bone structure. What makes it unique is that it goes beyond basic GAN image translation. It introduces domain knowledge and conditional constraints into the generative process using two main ideas: a pre-trained disease classifier that guides the model to train regions that are medically significant, and a masking mechanism that identifies the exact regions in the image affected by the artifacts and limits modification to only those regions. These features ensure that the model is not blindly cleaning the image, it's acting with precision. Now let us look briefly at the components of Capture GAN. A detailed architecture would be later in the video. So, first of all, the main backbone of the cycle GAN is built on dual generator and discriminator setup. This involves generators and two discriminators. One generator learns to remove artifacts from DCT images and the other learns to reintroduce them. This dual process enforces cycle consistency, helping the model learn meaningful transformations between corrupted and clean image domains. Secondly, Capture GAN uses masking mechanism. During training, the model generates binary masks that highlight artifact affected regions. These masks are computed by comparing the generator's output to their inputs and detecting where modifications have occurred. The third component is the integration of a pre-trained classifier based on ResNet 18, which is trained to detect bone marrow edema. This classifier is embedded into the training loop and evaluates the output of the generator. Now let us look at the significance and impact of Capture GAN. First of all, it improves clinical usability. It preserves edema features and bone integrity, which are often distorted or lost in conventional GAN-based image enhancement models. This makes it especially useful in settings where radiologists might have limited experience with DECT interpretation. Secondly, it outperforms existing model. The authors benchmarked Capture GAN against popular image translation models like AdGAN, StarGAN, and even CycleGAN. Capture GAN showed higher classification accuracy, better structural similarity, and more faithful image restoration based on metrics like F1 score, SSIM, and PSNR. Third and the most unique feature for Capture GAN is that it operates in an unsupervised condition. That is, there is no need for paired images. It learns entirely from unpaired DECT images, making it practical, scalable, and ready to be integrated into real clinical workflows without demanding extra imaging or manual labeling. Overall, Capture GAN is an elegant solution to a real world problem, combining the strengths of the unsupervised learning with domain specific constraints to improve the safety and reliability of AI enhanced medical imaging.
Now, our next part is deep dive into DECT for bone marrow edema. Let's expand on dual energy CT for bone marrow edema. DECT systems acquire data at two different X-ray energy levels simultaneously because different materials like bone, soft tissue, and contrast agents, or in our case, fluid indicative of edema, attenuate X-rays differently at various energies. This dual energy information allows for material decomposition. We can generate virtual non-calcium images or water equivalent images which help in highlighting fluid accumulation within the bone marrow, which is a key sign of edema. Moving on to next slide, we will now learn the nature of artifacts in DECT. While powerful, the reconstruction process and the physics of DECT can lead to various artifacts. These can manifest as streaks, blurs, or regions of altered intensity. The critical problem, as mentioned, is their appearance. In DCT images of bone, these artifacts can closely resemble the subtle patterns of fluid infiltration associated with edema. Second, obscuration. An artifact might overlay an area of edema, hiding it from view and complicating the diagnosis. Third is mimicry. An artifact might create a pattern that looks like edema where none exists. So, this ambiguity necessitates extensive training and experience for radiologists to confidently interpret DCT scans for BME. Now, the next part is why existing unsupervised methods struggle with DCT. So, unsupervised image translation networks like CycleGAN or AdGAN are powerful for style transfer or domain adaptation in natural images. However, their direct application to DCT artifact removal faces significant hurdles. So, what are these hurdles? First is pathology artifact similarity. This is the foremost challenge. If the network learns to transform artifact domain to clean domain and artifacts look like edema, it might then learn to remove edema. Second, attribute specificity. In models like AdGAN, if artifact is designated as an attribute for removal, the network might struggle to differentiate it from fine edema textures, which potentially alters both. Third is risk of information loss. Efforts to enhance specificity, which means correctly identifying artifacts, might inadvertently reduce sensitivity, which means missing true edema. So let us take an example, CycleGAN. While aiming for cycle consistency can sometimes lead to obliteration of fine internal bone patterns or the bone structural outline if not carefully guided. Now, moving on to the next part, what is the need for conditional approach? A generic unsupervised approach is insufficient. We need a method that is conditioned to understand the context. What is bone? What is potential edema? And what is likely an artifact? This requires more than just translating between two image domains. It requires incorporating prior knowledge and specific constraints. Our CAPTURE-GAN framework is built on this premise to carefully unveil the realistic underlying anatomy by removing artifacts, while actively preserving the critical attributes of disease. Now we will see the challenges which are being faced in DCT imaging for bone marrow edema. So first challenge is lower contrast than MRI. DCT offers less contrast compared to MRI, making edema detection more difficult. Second challenge is artifact presence. Artifacts are inherent in DCT image formation, obscuring or mimicking edema patterns. Third is interpretation complexity. Accurate diagnosis requires extensive expertise due to artifact pathology similarity. Now, we will see what are the existing AI solutions and what are their limitations. So first is supervised deep learning. It requires paired artifact and artifact-free images, which are impractical to obtain in DECT. Second is unsupervised methods. CycleGAN and AddGAN excel in natural images but struggle with DECT due to artifact pathology resemblance. Thirdly, risk of misinterpretation. Unsupervised models may remove true edema or distort bone structures, thus reducing their diagnostic reliability. Now, we will move on to next.
I am Pranjali, and today I will be explaining architecture of the Capture GAN. Capture GAN builds on the Cycle GAN framework, which is excellent at translating images from one domain to another, especially when you don't have paired examples. In the context of medical imaging, our goal is to remove artifacts from corrupted scans while preserving critical diagnostic information. Capture GAN introduces four core neural networks, two generators. First, GF, which removes artifacts from corrupted images, producing clean versions. Second, GA, which does the opposite. It adds realistic artifacts to clean images. It uses a mask to control where and how the artifacts are applied. Two discriminators. DF helps ensure the output from GF looks like a real clean image, while DA evaluates whether GA's outputs resemble actual corrupted images. Alongside these, we use a pre-trained classifier which checks that the clean image still preserves key disease properties. We also use a non-neural mask creator, which generates masks to guide GA, focusing artifact synthesis on meaningful areas. One of the key ideas in Capture GAN is the dual consistency mechanism. This is what helps the network learn transformations that are both realistic and reversible. In the forward cycle, we start with a corrupted image. GF removes the artifacts, producing a cleaned version. That cleaned image is then passed through GE along with a guiding mask to regenerate the corrupted version. A goal for this generated output is to closely resemble the original corrupted input. This tells us that GF and GA are learning meaningful forward transformations. In the backward cycle, we flip the process. We take a clean image, corrupt it with using GA and a mask, then pass that to GF to clean it. The result should match the original clean image as closely as possible. These two cycles reinforce each other and help the network maintain structural and semantic integrity so that the diagnostic patterns remain untouched even as artifacts are added or removed. Beyond these cycles, we use identity mapping as a regularization strategy. If GF is given an already clean image, it should ideally return the same image. If GA is given a corrupted image along with a zero valued mask, which signals don't add new artifacts, it should also behave like an identity operator. This helps the network learn to leave images unchanged when it's appropriate, reducing unnecessary distortions. Now, let's quickly look at the architecture of the networks themselves. Both GF and GA use a REST unit based design. They include an encoder-decoder layout for compressing and reconstructing features, residual blocks to preserve important information, and squeeze and excitation modules to emphasize critical channels. We also integrate atrospatial pyramid pooling (ASPP) to capture details at multiple scales, important for spotting significant but small features in medical images. The discriminators DF and DA follow the patch scan architecture. Instead of evaluating the image as whole, they analyze smaller patches. This makes them better at catching subtle inconsistencies or local artifacts that might go unnoticed at a global scale. To sum up, CAPTURE-GAN is a robust framework that not only removes artifacts but does so in a way that preserves diagnostic content. The dual cycle mechanism, identity mapping, and carefully designed architectures work together to make this possible.
Hello everyone, I am Garv and I will be explaining the method details for artifact removal in dual energy CT imaging. So, before we dive into the technical components, let's quickly recap how CAPTURE-GAN processes images. The model works in two domains, one with artifact corrupted DCT images denoted as XA and one with artifact free images XF. In the forward cycle, what happens is XA is passed to the artifact removal generator GF, which outputs a clean image XAF. This cleaned image is then recorrupted by the artifact corrupting generator GA using a mask MI to recreate the original corrupted images. The backward cycle what does the opposite. It corrupts a clean image XF using GA and the mask MI and then attempts to restore it using GF. So these two cycles ensure that the model not only learns to clean images but also understands what an artifacts look like and how to reconstruct them realistically. This duality is crucial because in DCT imaging, artifacts can closely mimic pathology and simple denoising would risk removing actual edema. Capture Capture GAN solves that by training both removal and generation pathways together. So preserving pathology and with the pre-trained classifier. Like one of the most innovative aspects of this method is the use of pre-trained classifier called C. Its primary function is to ensure that while the generator GF removes artifacts, it doesn't also eliminate critical medical features, specifically edema patterns, which are essential for diagnosis. C is a binary classifier based on ResNet 18 trained to distinguish between normal and edema containing bone images. Importantly, C is trained before the main GAN is trained. So on a dataset of a bone DCT images from 56 patients. So to overcome data scarcity and imbalance, standard augmentation techniques like rotation and intensity jittering were applied. With this, it achieved an accuracy of 88.7% on a separate validation set, gives us confidence that it can accurately provide feedback to GF training during the GAN, GF during the GAN training. So this classifier acts like a watchdog, ensure that meaningful pathology is preserved in the cleaned images. So the next critical piece of CAPTURE-GAN is the mask creator, which generates binary mask MI to guide the artifact generator GA. These masks ensure that artifacts are only added or removed in appropriate regions rather than over the whole image, which could lead to blurry or loss of detail. MI is created by intersecting two intermediate masks, the artifact mask and the second is the bone mask. The artifact mask is computed by taking the difference between the corrupted image XA and the cleaned output XAF. This difference is threshold using Otsu's methods to isolate the artifact region. In backward cycle, an artifact mask is randomly selected from a pool of previously generated ones, ensuring diversity in synthetic artifacts. The bone mask, on the other hand, is generated by applying contrast-based segmentation followed by a graph cut refinement. This ensures that the artifacts are only synthesized within the bone structure. The final mask MI is the intersection of both, so it helps the model make localized corrections, preserving edges and texture elsewhere. Now let's look at how CAPTURE-GAN learns. It uses a composite loss function combining four terms. So the first is the adversarial loss, as you can see, ensures that both generator produce outputs that are indistinguishable from the real data. Second is the cycle consistency loss. Make sure that an image translated from the other domain and back still resembles the original. This is the key to maintaining the content. Third is the identity loss. It prevents unnecessary changes when clean images are passed through the generators. For example, GF should not alter XF. And finally, we have the classification loss as a fourth loss, from which the pre-trained classifier C, it penalizes the generator GF if the cleaned image loses the features that were important for diagnosis. And these losses are weighted as follows, like lambda for cycle consistency loss is 30, lambda for identity is taken to be 15, and lambda for classification loss is 1. These values were chosen based on the empirical testing to ensure a balance between artifact removal and pathology preservation. Altogether, this loss design forces CAPTURE-GAN to clean the image without compromising diagnostic integrity. And here we have the overall loss I'll capture. Now coming to the training setup and the hyperparameters, all networks were initialized using the Camming's normal method. Okay, so which is commonly used in deep CNNs to ensure stable gradients. The Adam optimizer was used with a learning rate of 0.0002 and momentum parameter set to 0.5 and 0.999. The model was trained for 500 epochs with a mini batch size of 4 using an NVIDIA A100 GPU. Each training image was random 224 by 224 crop to introduce spatial variance, and standard data augmentation techniques like flipping and contrast jittering were used to enhance generalization. This extensive training helped stabilize the interplay between GF and GA, resulting in artifact-free DCT images that still preserve subtle edema patterns.
We will dive into the experiments conducted by the researchers and the results they achieved. To rigorously test CAPTURE-GAN, the researchers started with a carefully curated dataset. The foundation was DECT and MRI images collected from 70 patients. The selection criteria were important. They specifically chose patients where MRI images were available for precise edema annotation, ensured the DECT and MRI scans were performed within a month of each other for comparability, and focused on cases with clearly identifiable artifacts. The dataset was then divided. A substantial portion comprising 1837 artifact corrupted slices and 1064 artifact free slices from 56 patients was used to train the CAPTURE-GAN model. Then, to access generalization capabilities, a separate set of 504 corrupted and 227 clean slices from 14 new patients cases, the model that never encountered, was used for testing. For consistency in model input, the region of interest from these scans were extracted and resized to 256 by 256 pixels. With the data in place, let's first look at some visual evidence. On the far left, we have the MRI scan, serving as a reference for anatomical details and potential edema. Next to it is the input DECT image, where you can often see artifacts, some of which are highlighted by the red boxes. The blue arrows are pointing towards area where pathological patterns like edema might be present. Now as we move across to the right, we see that output from various artifact removal methods. Pay close attention to the cycle capture gain column. You will observe that capture gain effectively removes diverse type of artifacts. Crucially, while removing these artifacts, it does an excellent job of preserving the subtle edema patterns and the overall gray tissue structure. When compared to other unsupervised methods shown here, CAPTURE-GAN often demonstrates a superior ability to strike the important balance between artifact clearance and preservation of diagnostic details. This slide presents quantitative results based on the performance of two specialized AI classifiers that evaluated the process image. The chart shows different methods along the x-axis. The higher red bars indicate the accuracy of an artifact detecting classifier. A higher bar means the model was more successful at removing artifacts. The darker blue bar represents the F1 score from a disease detecting classifier. A higher F1 score here signifies better preservation of the edema patterns. If you look at the cycle capture gain on the right, it stands out. It achieves a high score for artifact detection, meaning it effectively removed artifact. Simultaneously, it scores very well on edema preservation. This demonstrates capture gain's strength in achieving a critical balance. It's not just removing artifacts, but doing so while carefully maintaining the diagnostically relevant information. A key concern when any image enhancement technique is whether it might inadvertently degrade images that are already of good quality. So the researchers asked, does capture gain degrade clean artifact free images? The image stripped at the top shows the result when artifact free images were fed into different models. As you can see, output from cycle capture gain looks remarkably similar to the ground truth input truth. The table below shows metrics like PSMR, peak signal to noise ratio, SSIM, structural similarity index, and MAE, mean absolute error. For capture gain, the PSNR and SSIM values are high and the MAE is low, indicating high fidelity and minimal deviation from the original clean image. Capture gain maintains high quality on clean inputs, causing only minimal alterations while preserving intricate bone structure and delicate tissue details. This is important because it confirms the model's reliability is targeted at fixing artifact without compromising already good image quality. To understand the specific contributions of capture gain's unique components, the researchers conducted an ablation study. This involves systematically evaluating the model with and without certain parts to see their impact. Let's look at the key takeaways. When you compare a basic cycle gain to the full capture gain, which includes the pre-trained classifier and the masking technique, there is a significant performance boost. The numbers clearly shows the full model is superior. Looking at the ACC artifact column, each component incrementally improves the artifact removal accuracy. For instance, cycle gain is at 70.24%. Cycle capture gain without mask improves to 81.35%, and the full cycle capture gain with mask reaches 87.70%. For the F1 score, the impact of the edema classifier is particularly drastic. Basic cycle gain has a very low F1 score of 26.67, indicating poor edema preservation. Adding the classifier in cycle capture GAN without mask jumps this to 77.52, and the mask provider further left to 80.33. This shows the classifier is crucial for protecting those subtle disease patterns. Perhaps one of the most compelling findings is that the image filtered by capture GAN actually enhance the performance of a separate edema classification model. The F1 score for edema detection on the original unfiltered image was 75. After processing with the full cycle capture GAN, this improved to 80.33. This is strong evidence that the cleaning process is generally beneficial for subsequent diagnostic tasks. The results clearly demonstrate that capture GAN successfully reduces artifact in challenging dual energy CT images. Critically, it achieves this while preserving essential diagnostic information, namely the subtle pattern of the bone marrow, edema, and the overall bone structure. Furthermore, in the comparison made, capture GAN generally outperforms other unsupervised methods in achieving the delicate but crucial balance.
Hello everyone, I am Mayank Goel and I will be presenting the conclusion for this paper. Let me begin by summarizing the core problem and the approach this paper takes. Dual energy CT or DECT is well suited for detecting bone marrow edema or BME because it uses two energy spectra to highlight differences between water and fat. In theory, that should make edema stand out clearly, but in practice, however, DET scans often come with serious artifacts. These artifacts, whether they are beam hardening streaks, scatter noise, or photon starvation, can mimic real edema or completely hide it. Experienced radiologists can sometimes recognize and ignore these artifacts, but it takes a very high level of expertise to be certain. For a less experienced interpreter or someone under time pressure, distinguishing artifact from genuine pathology becomes a major challenge. Now we ask, why can't we simply collect pairs of clean DCT scans and artifact DCT scans to train a supervised network? The short answer is it's not feasible. You need to scan the same patient twice, once under ideal conditions and once under artifact inducing conditions. To produce those paired examples, to that approach is both unethical and impractical. You cannot subject a patient to extra radiation or deliberately induce artifacts in a clinical settings. Because of this, traditional supervised learning models where you feed the network paired inputs and outputs are essentially ruled out. This work introduces CAPTURE-GAN, an unsupervised framework crafted precisely to tackle these challenges. At its heart, it is a cycle GAN inspired architecture, which means it can learn to translate between two domains, artifact laden DSCT and artifact clean DECT, without ever needing paired images. But CAPTURE-GAN goes further by incorporating two critical components that are essential for this medical imaging task: a pre-trained disease classifier. We train a separate classifier in advance to recognize true BME patterns or DECT images. During training, this classifier provides a conditional constraint. If the generator tries to remove or alter genuine edema signals, the classifier penalizes that action. In other words, the network is guided to preserve actual pathology rather than inadvertently eliminate what looks like artifact but is actually disease. This is what we mean by pathology aware artifact removal. The second point is an automated masking strategy for bone structure. Bones generate very strong CT signals. If the generator begins over smoothing or erasing bone details, you end up losing key diagnostic informations like turbicular patterns or cortical boundaries. To prevent that, the authors use an automated mask that identifies bony regions and effectively locks them in place. The generator is only allowed to modify voxels in the marrow region, where artifacts tend to appear. This ensures that the cortical bone, fine tubercle, and other structural details remain intact, while the network focuses its effort on removing artifacts from the Marrow space. By combining these two elements, a pre-trained edema classifier that enforces pathology preservation and a masking mechanism that protects bone structure CAPTURE-GAN can generate artifact-reduced DCT images that keep all the subtle signs of true BME intact. This is the crux of the solution, and it directly addresses the impracticability of supervised learning on paired data. Next, the authors evaluated CAPTURE-GAN against several state-of-the-art supervised image translation methods. I will go through the four points they highlight. Artifacts of various types are effectively removed, producing visually cleaner DACT images. In their experiments, CAPTURE-GAN consistently reduced beam hardening streaks, scatter noise, and other common DECT artifacts. When you compare the original scans side by side with the CAPTURE-GAN output, the difference is striking. The cleaned images show uniform grayscale in areas where streaks used to appear. This visual clarity is the first evidence that the framework is successfully targeting artifacts rather than merely smoothing everything. True BMI patterns and fine bone structures remain intact. The network does not oversmooth or erase subtle pathological details. Even if the artifact is adjacent to or overlapping a real edema region, CAPTURE-GAN preserves the shape, size, and intensity of the edema. Likewise, cortical lines and tubercular architecture, features critical to diagnosing conditions like osteoporosis or microfractures, are kept crisp. This confirms that the pre-trained classifier and the masking mechanisms are doing exactly what they're supposed to, prevent the network from throwing the baby out of the bathwater. CAPTURE-GAN outperforms existing supervised approaches. For example, standard cycle GAN, attention GAN, and star GAN in balancing artifact clearance with feature preservation. When the authors ran a standard cycle GAN on the same DEC dataset, they found that the cycle GAN would sometimes completely erase mild edema, mistaking it for artifact. Attention GAN, designed originally for facial attribute manipulation, and star GAN also struggled to maintain medical fidelity. In contrast, CAPTURE-GAN struck the optimal balance. Artifacts went away, but true BMI remained. Quantitatively, metrics like structural similarity and peak signal to signal ratio were higher than those achieved by competing methods, indicating better overall image quality without pathological loss. Crucially, when the artifact filtered images are fed through a downstream edema classifier, the classification, accuracy, and confidence improve compared to using the original artifact laden scans. In another word, CAPTURE-GAN doesn't just look better, it translates into better diagnostic utility. The author took the same pre-trained BMI classifier I mentioned earlier and tested it on three images set: the raw DECT images cleaned by competing unsupervised methods, and images cleaned by CAPTURE-GAN. This classification accuracy went up by significant margin, roughly a 10% increase over the unprocessed scans when CAPTURE-GAN outputs were used. Confidence scores measured by softmax probabilities were also notably higher. This means that CAPTURE-GAN's artifact removal not only makes the scan easier to read visually, but it actually helps the classifier and by extension a human radiologist. Overall, these achievements demonstrate that CAPTURE-GAN is not just a cosmetic filter, it meaningfully enhances the downstream clinical tasks. In summary, CAPTURE-GAN offers a straightforward yet impactful strategy for improving DACT image quality by imposing conditional constraints via the pre-trained disease classifier to protect true edema and the automated masking mechanism to protect bone structure. Looking forward, the paper outlines three main directions. The clinical impact evaluation. The next step is conducting formal reader studies. You have to recruit both radiologists, both experts in musculoskeletal images and general radiologists, and have them read DECT cases with and without CAPTURE-GAN's artifact detection. Second, support for less experienced interpreters. DECT scanning is still relatively specialized. Many smaller community hospitals or clinics lack radiologists who regularly interpret DECT for BMI. And the broader applications can be the principles behind CAPTURE-GAN can be used in way other fields other than DECT and BMI. For example, it can be used in MRI motion artifact reduction. It can be used in PET attention correction artifacts. It can be used in metal artifact reduction in standard CT. In each of these potential applications, collecting paired artifact versus clean data is equally impractical. So an unsupervised conditionally constrained approach like CAPTURE-GAN could be highly valuable. The presentation was based on the paper CAPTURE-GAN Conditional Attribute Preservation through Unveiling Realistic GAN for Artifact Removal and Dual Energy CT Imaging. It was given by a person National University in Korea. Thank you for all of your attention and for listening to our presentation.